doing, you know. No big Al. Working like an ocean butter, baby. Nice job, Alan. I decided he wanted to dance everybody, give everybody a good laugh. We'll show it again at staff meeting just so everybody makes sure to see it again. Good evening. Tonight we're going to talk about diabetes a little bit. Guys, got a lot of slides to cover because we want to. This is a pretty in-depth lecture, but it goes beyond just sugar and insulin. We want to talk about the reasons why the diabetes and how that process works and what drugs that we give and why they do what they do. Because it's important that we understand more than just the sugar and more than just the insulin in that process. So it's not just about avoiding the cookies and the bread and the cake and anything else that's edible, but this affects over 200 million people in the United States right now. So this becomes a huge population for us to be able to deal with. Some of our own staff even may have diabetes or some form of it, and it's I wasn't going to point to anybody, but since Drew did. But guys, the thing is about this disease process is it does not affect the age. It's not specific to gender or to occupation. Also, it's not always just a dietary problem. It's not always that you just ate too much. You eat too much all the time. But it's a matter of a disorder of the fuel metabolism. So how do we get to use that energy? We're going to talk about it. So some of the healthcare myths are, some of the processes of this is it's not just about being overweight or being lazy or laying around, or the diabetic did this to themselves this time because they don't taking care of themselves. It's not about that they eat too much sugar or not enough sugar. And EMS only needs to worry about the blood glucose measurement, and that's all. That's not part of it. We've got to worry about a lot of different things talking about this process. So it's all in the same name. We have diabetes type 1, diabetes type 2, and then we have diabetic, and where's Kim? Say the last one. Insipidus. Okay? The insipidus portion of it is unrelated to diabetes because the original word of diabetes means passing of water like a cycle. And so we're going to break that down here a little bit. We're going to understand that process. Both forms of the diabetes has to do with excessive urination. Part of the body's thing is they're trying to, with an antidiuretic, a hormone, it's trying to get rid of that sugar by a urinary process and trying to use osmosis to do that. But it goes way far past the long-term, because the long-term complications come in, and we start talking about microvascular disease process. This is where we start talking about CVAs, peripheral vascular disease, or PVD. We start talking about peripheral artery disease or coronary artery disease. Also on the microvascular side, I'm sorry, that was the macrovascular side. On the microvascular sides, we start worrying about our retinas and our kidneys and the shutdown of those processes over time by clamping blood off to these areas. At the same time, the nervous system kicks in, and this is where we have our peripheral neuropathy, and becomes a whole other problem from high blood sugars for over a large period of time, and that destroy all the protective sheaths around our muscles. At the same time, on the immune side, this is where hyperglycemia starts to really affect the leukocytes. So I have trouble fighting bacteria over time. As you can see, a lot of times your diabetic patients may have diabetic ulcers that don't heal. A lot of that has to do with A, the blood shunning from that area, and B, I can't fight infection because I've destroyed leukocytes from long-term hyperglycemia. You can see 29.1 million people across the United States are affected by some form of diabetes. As you can see, in West Texas, we're fairly moderate there. We have about 17,800 residents in Lubbock County alone, per the CDC's registration, that are diabetic patients. That's a large number of people that affects. I'm just glad I don't work over here, because that's the big, thing's a big portion. It may not be too bad to work over here, but you get down to the deep south and sure comes a problem. What?
I guess smoking weed fixes diabetes.
Colorado did pretty good with it. So understanding diabetes goes beyond the insulin. Okay, this is the insulin molecule, and we're not going to get into it quite that deep, but we'll start breaking it down from there. So where does the insulin dose come from? First of all, insulin is made in the pancreas. It comes from the pancreatic region. It starts to dump into the body system at that point, and if there's no insulin, there's no glucose into the cell. You have to have the insulin to make that work. We're going to talk about how that all comes together. In non-diabetic people, anytime we have elevation of blood glucose, so say if we've eaten a big meal or you drank a big beer, Crown and Coke, whatever it may be, then that's going to increase blood sugar. As soon as you start increasing blood sugar, it senses that, and the pancreas starts to produce insulin. It takes care of those sugars and makes them usable until it's got it down to back to a therapeutic level, and then it cuts itself off. So due to the large size of insulin, insulin can't enter the cell. So it has to come into a receptor, and the insulin tags onto that receptor and opens a doorway to where my glucose can come in as my gluten-4 comes up into the cell and starts receiving that sugar as usable sugar at that point. This happens in the skeletal muscles, in the skeletal region, anything that's using sugar. It has to have the gluten-4 to arrive at the cell membrane in order to attach and allow the gluten-4 to come up and allow the blood sugar or the glucose to enter the cell. In addition with that, gluten-6s are starting to begin to form, and that's what we call our usable sugar, and that's where it gives energy to the cell. It's just like a doorbell. If I ring the doorbell, somebody's going to come to the door and answer it. They're going to open the door, and they're going to allow us to come in. Gluten-4 works that way by opening those signals in the membrane in order to open the door to allow glucose to move in to move to gluten-6. So let's talk about an insulin review. Once again, insulin is formed in the is a natural hormone released by the pancreas. With the increase in blood glucose concentration, it's going to dump more insulin into the system. This increase is certain to amino acids. Also, it increases acetylcholines, which is going to help stimulate our vagus nerve, which can also assist in dumping more insulin into the system. So then we start talking about our brain and our CNS, because we all know that our brain operates off of a couple of different things, oxygen and sugars. As we talk about that, but the brain doesn't need peripheral insulin in order to use, to make sugar like it opens the cells in order for the gluten-4. It has gluten-1, which absorbs the glucose at that time, and it allows the signals of the brain to use that insulin very quickly. Also in the CNS transports gluten-3 to the nerves and gluten-5, and so it's going to help absorb that in, so it doesn't need the peripheral insulin like our body does. Glucose levels are known to be twice as high in the brain and the CNS as it is in the other parts of the body. So why is this important? Without peripheral insulin and active transport slowing these things down, the brain can rapidly detect hypoglycemia. Therefore, it triggers the insulin drive in the pancreas and says, I need you to start kicking out more quickly. Okay, so let's break down our insulins real quick, because we see these all the time, but it's very hard to know which insulin's what, so let's start breaking it down. We have our Humalog and our Novolog. The onset of these are between 10 and 30 minutes. The peak happens in about half an hour to 3 hours, and the duration is only going to last about 3 to 6 hours. So our patients that are on Humulin, Humalog, and Novolog, they're going to be our more short-acting type of insulins. Then you move into our slower acting, but are still, this is our Humulin R, or our regular insulin, or Novolin N, Novolin R. The duration is going to be about 30 to 60 minutes. At the same time, it's going to peak at about 1 to 5 hours, and it's going to hang around for about 6 to 10 hours. Then we move into our NPH, which neutral. I got to think neutral. I had it memorized and I forgot what it was. Humulin N and Novolin N. This is going to be a peak or an onset at about 1 to 2 hours. It's going to hang around 6 to 14 hours, and then it's going to peak at, it's going to end at about 24 hours. So these are going to be our more long-term insulins that our patients are going to need to get them through, like long-term through the night. You'll see that a lot of times they'll give these in the evenings, which will help push through the evening hours. And then our long-term, our Lantus, that's where it's going to be. It's peaking about an hour or so. There's really no peak time to it, and the duration, once again, is about 24 hours. So you see a lot of these patients, a lot of times, and we just look, oh, it's Humulin R, it's Humulin N. We need to know what that is, because how long ago did they take it? Because it's going to tell me how long is it going to take for that insulin to start kicking in and being making usable, so my gluten-4 can come up and start receiving to the cells. And this is something that I guarantee you weren't taught in paramedic school. In fact, our nurses in the room, they drill this into them, but paramedics are never taught. They're just taught, oh, they're on insulin. Well, a big part of this is, when did they take that insulin? How long ago did they take it? Because that kind of gives me a general idea of how this insulin is working and when I'm going to be able to get some benefit from that insulin. So let's talk about type 1 diabetes. Type 1 diabetes, this is where we have a lack of insulin production. This is where the patient doesn't make insulin or makes a very, very small amount that is not really usable. It's not enough to sustain what we need it to do. It also has a lot to do. Also has a lot to do with the beta cells. As these beta cells are destroyed over time, that's where we lose that they lose that ability to be able to produce that insulin, and that's where part of the pancreas, where it is created, is in the where the insulin is created, is in the pancreas through the beta cells. The symptoms of this, they're hyperglycemic, will start to develop. These patients do require insulin on a daily basis in order to remember, open that doorway so my gluten-4 can turn my glucose into usable sugars. So what destroys the beta cells over time? And remember, this is going to be, a lot of times, our older patients with our type 1 diabetes. These are, we have infections over time. Viral infections can cause destruction of the beta cells over time. It's also an autoimmune response. So this will help, this starts to break it down of why the pancreas has all of a sudden stopped making insulin, and it has all to do with the beta cells. Some other things that can cause this are mumps and rubella, toxic chemicals that may have gotten into the body and started to break down, and also kids that are exposed to cow's milk before about the third month of their life. That can start, the bovine enterovirus will affect the baby and start breaking down those beta cells quicker. So signs and symptoms, of course, is hyperglycemia. We're going to have an increase in urination, increase in thirst, an increase in hunger, because they're trying to feed the cells. Their body's saying, I need more sugar, usable sugar, but it's not turning it into usable sugar. Nausea, abdominal pain, blurred vision, and fatigue and weakness. So why frequent urination? The body's trying to diffuse itself. It's noticing that the blood sugars are high, so it's trying to excrete it from the body, and the only way it knows to do that is through urine. Why are they thirsty? Their body's trying to hydrate itself. It thinks it's dehydrated because the sugars are so high. Therefore, it tries to, it gives you the ability. That's why a lot of times with pre-hospital, we've moved in to starting an IV on these patients to help with that dehydration and start to help dissipate some of that sugar and excrete it from the body. Why are they hungry? These cells are, they don't have glucose in the middle of the cell for the gluten-4 to absorb. Therefore, the body says, I need more sugar. So it wants it to pour more on board, but it's still not able to make it into the usable because of the insulin's not there. Patients a lot of times can remain nauseated with abdominal pain because of the electrolyte imbalance from the dehydration. Blurred vision occurs because hyperglycemia affects the focal length of the lens. Seizures, common with cerebral fluid that's on board from the osmosis not being able to take place from the sugar. And weakness and fatigue from hypokalemia and hypovolemia. So let's talk about type 2. This is usually, they have adequate sugars, but at that time the insulin is resistant to the cell. It can't get into the cell membrane. There's not that open door at that point where that insulin's able to tag on, and so it pulls the gluten-4 up to be able to absorb and make it into usable. This is the most common form of diabetes. About 90 to 95% of diabetics are type 2 diabetics. Going back to the door, we're going to ring. Hopefully somebody's going to come. When the insulin binds to the receptor, that's the pressing of the doorway. However, there's no answer at that point. And so we've got to give a drug to be able to promote, at that point, to be able to promote acceptance of that sugar to be able to get the gluten-4 in. These used to be called our non-insulin dependent diabetics, but actually over 40% of our type 2 do take insulin of some form by an injectable form. So what causes it? Now this is caused a lot of times by genetics, it could be race driven, it could be obesity, a lack of physical activity, and increase in age. So as we get older in life and we get bigger and we start to get more lazy, you're going to see this population start to pick up with our older population with type 2 diabetes. This a lot of times is caught by routine lab values being drawn. This may be, they just be going in for a checkup, and we start to draw certain lab values, and they start picking up that this patient could be a diabetic patient. So let's talk about some of the general type 2 diabetic medications. Glucophage. What glucophage does is it inhibits the production of in the liver and slightly reduces glucose absorbed by the GI tract. So it's going to help promote glucose production from the liver being released. And it's going to be important here in a little bit when we start talking about glucagon here in just a little bit. We talk about our drugs like glucobride, and this is going to stimulate the release of insulin from the pancreas. So we're trying to spur the pancreas on at this time and get it to release the insulin. You've also got your Avandia and your Actos. This reduces insulin resistance and reduces the insulin production coming from the liver. You've got drugs, this is some of the newer class, the Prandian, and what this has done, this is increasing insulin. It releases through the pancreas, but it also acts as kind of a potassium channel blockade. So we run into some problems with that on the cardiac side. We've also got the Glucobay. I'm not real familiar with this class. Are y'all seeing a lot of these anymore?
Because I think they're pricey.
They're real pricey. So this is some of the newer stuff here. This causes a delay in absorption of carbohydrates in the small intestines. So it's going to delay the amount of sugar being released. And then you've got your Januvia. This is enhances the action to increase the hormone to release the insulin to start to spur that along. So the pre-hospital assessment. First of all, I need to know, are they a type 1 or are they type 2? The signs and symptoms and the duration and the type. How long have you been a diabetic? Are you just new at this, or is this something that's been a chronic problem for you? Any recent changes in medication? Yes, they just added this new drug to me or that new drug to me. Recent illnesses. Guys, when we're sick, we're going to be burning more sugar. That may cause that hypoglycemia or cause us to store and move it to the external side where we're not able to get the sugars in through the gluten-4. Last, insulin or oral intake. This becomes very important for us. And what type of insulin is it? Is it Humulin N? Is it R? Because I need to know how long is the absorption rate? How long, when's my peak time? So if I'm checking the blood sugar and it's 560 and they took their insulin 30 minutes before I got there, I may be getting into that window. Hey, I may start seeing a change pretty soon. And then is there any new pain or discomfort, anything that I haven't seen? Also, our patients with renal concerns. Of course, we need to be concerned with diabetes and with hypertension. A1C. This is an important question to ask. Have they drawn an A1C? A1C is a very specific glucose molecule that they're checking for. It binds to the hemoglobin at that time, and it'll stay around for 30 to about 68 days or so. And so it stays around a long time, so they're able to check and see if somebody's a diabetic, because if you're starting to have these signs and symptoms, they can draw the blood, and they're going to, that glucose is going to stay bound to the hemoglobin as long as that red blood cell is alive. A red blood cell should stay alive between about 38 to 60 days, give or take a little bit, given that they're a healthy patient. So this gives us a good chance to be able to see what is a 2 and 3 month window of what their blood glucoses have been. So let's review the type 1 and type 2 again. The diabetic onset. It's usually an autoimmune cause on type 1. No insulin is produced by the pancreas. These patients, if they get hyperglycemic, will be in DKA at that point. The most common cause of the hypoglycemia is they fail to eat or drink properly. Stress can also cause to burn sugar quicker, and so that can cause hypoglycemia. Typically, their appearance are going to be thin, so probably some people don't have that.
So it's just typical.
What? That's typical. This is typical. And they're usually our young patients. Type 2 diabetes, this is where it's usually a lifestyle or a genetic cause. Insulin resistant to the cells, so they're not able to open up. Insulin's not able to come down and bind so that the gluten-4 can open up the cell in order to receive the sugar. Most common cause of the hypoglycemia is they have an imbalance in their oral medications, stress, or excessive amounts of workout, so they're burning those sugars quickly. Typical appearance is they're usually well-nourished and obese. And these are usually our older patients, remember. So let's talk about our hyperglycemia real quick. Supportive therapy, once again, with our cardiac monitors. These are things we need to do. Guys, this can affect some of the potassium that's in the body. That's going to affect the conductivity of the heart. And so I need to be cautious of that. Put them on the heart monitor. If no signs of pitting edema or dialysis, then make sure to give them some fluid. That becomes very important because I need to start displacing some of that sugar in order to make it wash out to get to where they're starting to urinate, and they're going to start flushing some of that out naturally. So let's look at a case real quick. They were called to this call, and the blood glucose was 460 when they got there. She's experiencing this for approximately about a week now. She denied any shortness of breath, any shortness of breath or chest pain, and she wanted to go to the hospital. So as you can see, diabetes right here, but she's also had an MI, so that's a higher risk, and may have some potassium issues at that point I need to be concerned about. So they get her in the truck. There's really not any acute distress, but they do note a high blood sugar. So they get her in the back of the truck, cardiac monitor. They do give her an IV fluid, and they've done a nice job documenting a 500 fluid flow is given to hyperglycemia, and that's part of that new protocol that we have built in. Then they've gone in and just talked about here how they what they've done. They secured it to the cot, transported to the hospital. The big point is here is that we've got to start getting this fluid on board as long as we don't have pulmonary or pitting edema or they're not a dialysis patient. We need to start helping them flush some of that sugar out. Now, some of the things that we need to talk about is If she is on insulin, what type of insulin? That becomes a very big point for us because I need to know, did she just take it? Did she take it 2 hours ago and I'm still this high? So where did we start at? Because I should be peaking with that certain type of insulin or not. As you can see, the vital signs were stable, but you can notice this was at 20:02 and at 20:18, so 16 minutes, they dropped the blood sugar about 65 points right there already. So it brings it down from 546 to 486. And let me ask, how many people, if you check a blood sugar in the house, how many do it back in the truck with a different glucometer? It's probably a pretty good idea because in the hospital world, in the pre-hospital world, the glucometers we have are good, but they're probably not as accurate as serum glucose at the hospital on a blood draw. So we need to check it from a couple of different, especially if something's abnormally high or abnormally low. Hypoglycemia. Let's talk about the pre-hospital care. Once again, supported with heart monitor. Address the blood sugar issues. If they're conscious, alert, and oriented, you may choose to go ahead and go with and their swallow reflexes are intact, go with some oral glucose. If they're unconscious or they start to get altered level of consciousness, then I want to start giving my D50. Remember, I have to cut those doses in half with my with my children, pediatric patients, or I can have the option of going to glucagon if we're unable to get IV access. So we're going to talk about glucagon more here in just a minute, how it works. So here's our patient. We arrive on scene. Some of this there's some stuff done out so we can put this on YouTube. But they notice that the blood glucose just reads low. Can anybody tell me with the new glucometers what low means? It's below what? 12? I think it's 12 or 10. The brand new ones are 20 now? Okay, the old ones were 10? Okay. So they're below 20 on these new ones. And so we need to be very cautious of knowing, kind of gives me a general idea of where that's at. So they're lying in bed, the patient's non-responsive to verbal and painful stimuli. They've done a great job documenting once again of what they find. They start an IV, they give them D50, 25 grams, and then they notice that the blood glucose is coming up, but the patient's still not reacting well. And so they elect to go ahead and give another 12.5 grams at that, grams at that time in order to start to bring it up. Then the patient begins to whisper, and we're going to talk more about this here in just a second. So they've done a really nice job here talking about, they talked to the family here, and they notice that the blood sugar comes to 86, but the patient is still not really moving like she normally does and not able to answer questions. So they elect to go ahead and give a little bit more in order to get the blood glucose up. The family states that she normally runs in the 200s. So it is appropriate for you to go ahead and treat and give a little bit more sugar in order to return them to their normal mental state. As you can note, though, that the blood pressure here is a little bit hypotensive. 97/50. Once again, blood glucose of 86 here, and then turns out to be 109. After you've given that much sugar and you're still only 109, that's got to be a concern. Something's going on. And then I'm hypotensive on top of that. That becomes very hard to manage this patient because you give them a lot of fluid. What are you doing with sugar? You're washing the sugar out. You've got to pay attention to that. But does she need a little bit of blood pressure support? Possibly so. So you've got to really weigh that. I'm going to have to stay up on my sugars at that time. Once again, they did an IV here. Unsuccessful. They did another IV, unsuccessful, and they elected to go to an IO in order to give sugar and fluid. Okay, that's a hard spot because you got to weigh that of, am I going to give sugar through an IO? You know, is it worth starting an IO? And Dr. Troutman's going to talk more about this at the end. They gave a lidocaine bolus, and they gave the through the IO to help with the pain. They gave the D50. And they started getting the patient awake, like we talked about, went to 86, and then with 12.5 more grams, got it up to 109. Then this is where they gave the second round in order, and they documented once again, a very nice job documenting that the family status she normally runs in the 200s, and that they felt like it was important to go ahead and give another 12.5 grams. So would they have been bad if given another 25 grams here? Probably not, okay, because they didn't get a lot of success getting up where it was before. Let's talk about glucagon real quick, because a lot of people, I'm very opposed to glucagon initially until we started doing a lot of studies about how good it really is. Glucagon is a naturally occurring hormone that is released by alpha cells in the pancreas. It offers us an opposing force to insulin. When released, glucagon acts primarily on liver glycogen storage. So it allows them to start releasing the sugars from the liver at that point and start to make it into usable sugars. Glucagon is released throughout the day naturally. It prevents hypoglycemia between meals and while sleeping. This is what keeps us going through the night, normal healthy people, keeping our sugar levels therapeutic. While IV glucose is preferred over severe hypoglycemia, reconstituted glucagon can be given intramuscular, and the peak of it is about 13 minutes for it to start working. And for each milligram given, you should see about a 69. The literature says a 69 milligrams per deciliter of glucose. Now, how many grams of glucagon do we give? 1 to 2. The protocol says 1 to 2 milligrams. So you have that option, but just remember you're only going to get about roughly 70 milligrams a deciliter. So if it just reads low, we know that's below 20. That's going to get us up to hopefully a therapeutic level fairly quickly, but it may take up to about 13 minutes. In saying that, if I was to give, well, hang on. Let's get to this part. Reconstitute, it needs to be done in sterile water only, not sterile saline. The effects, it can cause severe nausea. At 2 milligrams, the increase in nausea, you have a large increase in nausea the more glucagon you give. It affects the smooth muscle of the GI tract, and that's what causes the nausea at that time. Contraindications is anybody with a pheochromocytoma. That's a non-malignant tumor that sits on top of the adrenal gland off of the kidney. After recovery, on a short time, there may be a chance you may be able to get an IV. It's not going to all of a sudden pop up, but if you do, you need to go ahead and give some D50 with that. And the reason why is because we have to replace the sugars that we've stolen from the liver. And it may take a little while for that to rebuild. This will peak in about, the glucagon will peak in about 4 hours. And it may take up to, and it may extend up to about 10 hours for a prolonged fast, and it may take 2 or 3 days to start replacing that sugar in the liver. That's why it's important we get them a meal. And if we can't get them a meal and they're still altered, and we get an IV, we need to give them some sugar, because we've got to start replacing the sugars that we've robbed from the liver. Okay, it's very important, and we start talking about when we're leaving these patients at home. This is why it's important. If we've given somebody glucagon at home and they're refusing to go to the hospital with us, I need to really talk to them about going to the hospital. It may take us a while. Once again, it may take several hours to replenish those blood sugars that were, or the glucose that was taken from the liver. And so I need to make sure that they're taken care of. I need to make sure they get a meal. They get sugars on board. It's going to take a while to replace that, so I need to encourage them to be transported to the hospital and to be taken care of there. Okay. So let's talk about a glucagon usage. They responded, 47-year-old male, lying on the floor, moving around, not responding to any questions, but he's moving around. He had taken his insulin at 5 to 6 p.m. And did not remember eating afterwards. They get him to the truck. The glucometer reads 11 milligrams per deciliter. They try to stick him a couple of times. Is this an IO candidate? Could be an IO candidate. I mean, it's something you got to weigh, and Dr. Troutman's going to talk about that more. But he's almost alert. He's able to respond to your questions somewhat, and he's moving around. So you know he's high functioning for 11 milligrams at that point. They're unable to get an IV at that time, and so they go ahead and give him the glucagon, and then they finally end up getting an IV, so they go ahead and give D50. Nothing wrong with that. Got to replace those sugars in the liver. Once again, the IV is unsuccessful ×2. They elect to go ahead with the 1 milligram of glucagon at that time, and then they end up getting an IV, so they follow it up with D50. And that's to help replace that. Plus, remember that onset of glucagon may be up to 13 minutes, which may take a little bit. The vital signs portion, he looks hemodynamically stable, 136/90, heart rate's 118. He started out at 11. By the time we're talking about 35 minutes here, and we're back up to 122 now. So it's going to start dumping, that liver's going to start dumping the glucose out and start to give it a little bit of sugar that's going to be usable at that time. So this is a critical case, and we want to talk about this case review at the end because it kind of incorporates a lot of different things. Hypovolemia with low blood sugar, and so you're kind of like, where do I go and which way? And they did a really nice job managing this. Where's Donnie? Is this? No? Because I don't have that. Do you have it?
I'm trying to pull my email up.
Okay, we can pull it up there for the reporting month. So the family on scene states the patient's been experiencing diarrhea over the past few days. So what do you know about blood sugar there? If they're diabetic, they're going to be in problem, okay? Because they're starting to pull that out, and they're going to be hemodynamically unstable at that point, or could be. They're going to be dehydrated. They stated that the patient loose bowel movements, and then they moved him back to the bed. About 5 minutes prior to EMS, they noticed he was unresponsive. Patient does not have a history of diabetes, though. So they're not thinking sugar's too much at that point. The patient is lying in bed with a diaper and a t-shirt in place. A fan is blowing in the room. Patient's respiratory becomes slower and is now almost agonal at that point, and GCS continues to be a 3. They notice he's cool and pale, where there's a fan blowing in the room, so you're trying to weigh all this together. He's noted to 5+ peaking on his skin turgor, absent radial pulses, so we know his blood pressure's low. His saturations are pretty good, 95 to 97%. They also get him to the truck, and they notice that his blood pressure, they're unable to get a blood pressure at first, and they finally get one with an NIBP of 79/53 with a heart rate of 110 to 115. At that time, blood sugar is noted to be 50. Well, what are we about to give him for his blood pressure? A lot of fluid. What's that going to do to that sugar already? He's already altered. So is that causing his alteredness? It's hard to tell. So they go ahead and they get a nasal airway in him. They do a 12 lead. They end up doing an IO. They're unable to get IV access. Nothing could be found. So they went ahead and gave the D50. They get blood sugar coming up. They try some Narcan to cover everything. When they give him Narcan, it responds to his respiratory cycle only, not level of consciousness. And so you're trying to weigh this of which way am I going to go with this? Because I'm trying to treat his sugar, trying to treat his hypovolemia, and I'm trying to treat his level of consciousness since it's not improving with any of our other means. They transport him to the hospital. At that time, he maintained his own airway without an ET tube as the patient started to come around with Narcan. So guys, this is a hard call because I know I need to give him sugar, but I know I need to give him fluid, and that's going to wash that out. And Y'all saw before, in just 16 minutes, they dropped at 65 points. He was already at 50, so he didn't have a lot of room to give a lot of fluid. But when your blood pressure is 79 and you're not conscious, you've got to start weighing that. So that may have to, you may have to really pay attention to our glucose levels, even as I'm giving fluid on a normal basis.
Perfect. All right, that's great talking about diabetes. Had a lot of level of detail. Is this working? Okay. So we're going to start doing kind of the Troutman take home at the end of it. Kind of, okay, what do we need to get from this? So this will be the first time we do this. So type 1 versus type 2, you know, it's important, but really for emergency medicine, who cares? Do I really care if they're a type 1 or a type 2 diabetic? What are you going to do different if they're type 1, type 2? You're not going to do anything different. It's important, but really when it comes down to emergency care, it doesn't matter. But what does matter is what they take. And we talked a little bit about, we need to find out what do they take for their diabetes. Are they on PO medications? Are they on insulin? Are they on short-acting insulin? Are they on long-acting insulin? And why do we need to know that? You know, if they're on a long-acting insulin, or especially the big one, hopefully everybody remembers, the sulfonylureas. Those are the folks that you go in, they're hypoglycemic, you give them sugar, now they're up, oh, I don't want to go, and you leave, and you return 30 minutes later, and they're what? They're hypoglycemic again. This is the big medications that will do that. And some of those long-acting insulins will as well, theoretically. They don't tend to do it as much, but they can. And certainly the long-acting insulins, if they eat or they get enough sugar on board, it usually won't drop them as much. But these sulfonylureas, if it dropped them once, it's probably going to drop them again. These folks, when they come in the ER, they get admitted for observation. So hypoglycemia. Don't forget about oral glucose. I think as a service, we probably don't use it as much as we probably could. You know, keep that in mind as a tool that we have. You know, obviously they need to be, they're not going to be completely awake, or they probably wouldn't be hypoglycemic, but we've all seen those sugars of 35 that they're still kind of talking to you, they're more kind of drunk acting. They can take the oral glucose, so don't forget about that. So glucose IV, that's probably the best option when somebody's really low. We all know that, right? But we can't always get an IV. So we kind of brought up the glucagon IM versus IO, which is better. So the two cases we talked about that used glucagon or used an IO, what was in particular about those cases? The patient was pretty unstable, weren't they? One of them, they were really hypotensive. The other one, there was possible seizures, some erratic behavior. So those folks were pretty sick. So they didn't need to just get glucagon in the thigh and stand back. They needed an IO, and we couldn't get an IV. So those patients warranted the IO. When it's a little more straightforward, okay, their sugar is 22, they're not really acting quite right, the rest of their vitals are fine, I can't get an IV, give them some glucagon. And go with the 2 milligrams. What do we do as a service? Do we generally give 1 or do we generally give 2?
Generally give 1.
Yeah, I would tend towards generally give 2. You know, we talked about it. It's going to raise you 69 approximately. You know, in reality, it probably raise you 50. So, you know, give 2, it's going to raise you 100, or probably in reality, it's going to be 80 or 90. So that's okay. So why not just give the IO, or just do the IO? Remember, these are diabetics, wound infection we can have. There is some reports of getting an osteomyelitis after injection of glucose into the bone. So that is a risk that we're putting the patient at. Now, if the patient needs it, let's do it. But just don't forget about the glucagon. And don't forget about oral glucose. Let's try to use that when appropriate. So hyperglycemia, you know, we could go to the ER right now, and I bet 70% of the patients are right here. And none of the doctors down there really would care. You know, you kind of get to this range of, you know, I've got diabetes, and yeah, your sugar's 310, and they're there because their foot hurts or something else is going on. So, you know, it's important, but again, in the setting of emergency medicine, it's really not a big deal. They've probably been 300 for the last week or for the last 3 years. Now, as we start to get higher, usually 350 and above, now we got to suspect other problems. One of them we really worry about is DKA. Y'all know what that is? Diabetic ketoacidosis. And it's a pretty cool, the way it works on your electrolytes, but you essentially get an anion gap acidosis. So you have low CO2, you have a low pH. There is a kind of tachypnic. Everybody in here's seen them. They're pretty dry, but they fix. It just almost seems magically. You start them on insulin infusion, give them some IV fluids, and they correct their gap. They get out of the DKA. So it's a pretty neat pathology we deal with. Then this is, technically these folks are sicker. This is not DKA. This is HONK, or hyperosmolar non-ketotic state. So this is more rare, but most of y'all probably, you may not have realized it when you saw it, because what's the glucose meter say? Just high, right? If it's over, was it 500, 600? Most of these people are going to be 900,000, 1,200 when they're in HONK. And they are very dehydrated, like 8, 9 liters low sometimes. I'll see somebody with DKA once a month or more. I might see that once or twice a year working in the ER. So it happens. It's not super rare, but we do see it. More whenever I see, a diabetic and they're not real hypoglycemic that we talked about we have to do, and they're not in DKA or HONK. More what it starts jogging my mind is what are the other issues that happen with folks with diabetes. And of course, wound infections. Everybody's seen the chronic type diabetic ulcers or diabetic foot, but also just acute infections, having a cellulitis or some kind of extremity infection, something you really need to look for. And then really the big one's chest pain. Diabetics with chest pain, we take pretty serious, right? They're much higher risk of having an MI. We wanted to just talk a little bit about our N4s, or refusals. We see some of these, they're getting sometimes pretty simple, just like 1 or 2 lines. And I think generally they need to be a little bit more robust. A few things that we need to probably always document is we need to document that the patient is appropriate, that they're awake, they're alert, you can say they've got a GCS of 15, but remember, generally the GCS has to do with neurological trauma, so we also need to say, because you can have a GCS of 15 and be drunk, right, and really shouldn't be making your own decisions. So you need to document that they're awake and alert and they're understanding the decision they make. And it's also good to give them a follow-up plan. Okay, we got your sugar up, it's better now. I'd like for you to go to the hospital. I understand you don't want to, but I really want you to eat something, call your doctor in the morning, and then document that you did that. Does that make sense? I think that's it. Y'all have any particular questions?